Hello, I'm Ann O'Day from the University of Kansas Cancer Center, and I have the pleasure today of moderating our tumor board. And I'm going to ask our esteemed panelists if they wouldn't mind going ahead and introducing themselves. We'll start out with Dr. O'Shaughnessy.
Hi everyone. Joyce O'Shaughnessy. I'm in Baylor University Medical Center, Texas Oncology, and U.S. Oncology in Dallas, Texas, and I'm a breast medical oncologist. Very nice to be here with you today.
I am Dr. Frank Piccini, radiation oncologist with Genesis Care in Michigan.
Hi, I'm Norman Woolmark. I'm professor of surgery at the University of Pittsburgh. I'm chairman of the NSABP Foundation and co-principal PI of NRG Oncology.
I'm Maxine Jockelson, and I am a professor of radiology at Memorial Sloan Kettering Cancer Center, where I direct the imaging for the Breast and Imaging Center. I'm primarily a breast imager with a little sideshow of doing PET scanning as well.
23-year-old with a p53 mutation and recent right breast biopsy demonstrating a fibroepithelial lesion with atypia concerning for a malignant phyllodes tumor. And the question that's being raised is, what is the best local therapy management for this patient, given the known p53 mutation and her risk for, future cancers and so on? So this is a patient who presented for high-risk MRI screening, given the known p53 mutation of entire body and breast, given again her p53 mutation. She didn't have any complaints, so this was just really asymptomatic screening. She has an excellent performance status. Her medical history, as I mentioned, significant for the Lee-Fraumeni syndrome. Her gynecologic history includes menarche at age 13. She's G0P0. She has an IUD since 2016. Her social history, really not significant. Family history, as we would expect for a person with a p53 mutation, breast cancer in her paternal grandmother, pancreatic cancer in maternal grandfather, esophageal cancer in her father, deceased at age 36. The p53 mutation was confirmed to be passed through her paternal side, osteosarcoma in her brother, who was deceased at age 25, also a known p53 mutation carrier. So her history here, in March of 2021, she had the bilateral breast MRI, which did demonstrate this 1.7 by 1.6 by 2.1 centimeter mass in the right breast. There was also a satellite lesion at 8 o'clock in the posterolateral right breast. Of note, she did have her COVID vaccine in the February prior to this breast MRI in the contralateral arm. She had a right breast ultrasound that showed 2 persistent masses in the right breast. The ultrasound of the right breast at 8 o'clock showed the fibroepithelial lesion with atypia concerning for malignant phyllodes, and the right ultrasound core biopsy of the 12 o'clock mass fibroepithelial lesion with nuclear atypia. Dr. Jockelson, we have some images from the MRI, if you wouldn't mind pointing out some of the important findings for us.
Sure. So our classic way of screening Lee-Fraumeni patients is they get whole body MRs, and then they get a separate breast MRI. And so what we have is a single view from the 2 views of the breast MRI. And, it's kind of a slightly unusual presentation for a phyllodes tumor. I mean, classically, they present as a palpable mass and often a rapidly growing mass. And here, what we have on the first slide is a mass in the central breast, and you can see this enhancing circumscribed mass. And the satellite lesion is, I have to admit, have never seen a satellite lesion on a phyllodes tumor. It's not typical, but certainly that's what it looks like here. And then in the second set of images, there is a second lesion that's more posterior and lateral in the breast, and those 2 were both biopsy proven to be phyllodes tumors. And on the images I see on the left, I don't see any significant abnormalities.
Perfect. Thank you so much. So Dr. Woolmark, if you might help us, how would you counsel this patient in terms of best local therapy management, given her young age and known p53 mutation?
Yeah, I don't think the challenge here is the phyllodes tumor. I think the challenge, as I think Maxine implied, was the screening for somebody with Lee-Fraumeni syndrome that has a cumulative risk of developing an event, certainly 50% or over for breast cancer. And I think that's the pivotal issue, and I think that's the strategy that needs to be defined at the outset. For a 23-year-old in whom this was discovered as an incidental finding, I think local resection of these lesions should be carried out, preferably with a margin around it. The debate as to what constitutes a malignant phyllodes versus a more banal entity of the same is controversial, and I've never been comfortable with those delineations. I think the likelihood of her developing a local recurrence again, which I don't think should be driving the management, is small. Certainly, there are reported cases of events that are extramammary, which are very rare, and I don't think play into the overall strategy that ought to be utilized. Is phyllodes tumor associated with Lee-Fraumeni syndrome? There have been reports in the literature, scattered reports of phyllodes tumors associated with p53 mutations, but again, not enough to draw any conclusions. There have been reports of phyllodes tumor in sisters. Again, these are all anecdotal. So from my perspective, I would perform local excisions in this 23-year-old at a wonderful age, and put in a strategy for screening, as Maxine defined in her comments relative to the findings on imaging.
Perfect. Okay. Any other comments? Dr. Vicini, do you want to comment anything about the role of radiation for phyllodes, or can you comment for us about that at all?
Yeah, well, just for p53, there have been actually 2 pretty good reviews just recently, one in Breast Cancer Research and Treatment and one in Radiotherapy and Oncology, showing the increased risk of developing cancers from radiating these patients. So this patient obviously doesn't have a big risk of a recurrent local recurrence if she does get a resection. So I'd be very hesitant to radiate this patient. I think that's the best message I could give you.
Perfect. Thank you. I appreciate that. Any other comments about this young patient with Lee-Fraumeni syndrome?
I'll just make a comment, which is just more of a gestalt and something I wonder about. One interesting thing I would talk to this woman about is that with subsequent generations, we have more data in this with germline BRCA certainly than we do p53 because it's so rare. But with germline BRCAs, it seems that the breast cancers can get younger with successive generations. I don't think we fully understand that, whether it's a greater degree of nutritional status and earlier age of menarche with today's modern life compared to generations ago, whether it be the utilization of hormonal contraception. For example, I don't think we know, but I was very interested to read some years back now that it's progesterone that really supports the stem cell population in a woman in general. The progenitors, the luminal progenitors are supported predominantly by progesterone. It's interesting. It leads to the stromal production of rank ligand, which is why denosumab is being considered as a risk reduction agent potentially in germline BRCA carriers. But progesterone is important, and she has an IUD that has the levonorgestrel, and it's just something I would visit with her about. We don't know. We do know that long time use of the hormone-eluting progestin IUDs. We do know that it does raise up the risk for breast cancer. Very, very nice New England Journal of Medicine paper. I think there's the best paper recently on this was about 3 years ago now, and it was from one of the Scandinavian countries, because they have the nationwide databases. They know the prescriptions and they know the outcomes, and it went through all of the various formulations of hormonal contraception, and the hormone eluting, the progestin eluting IUDs were definitely raised the risk. Now, these are modest risk raises, but I don't think we know as well in those who harbor germline mutations. And I don't think we know anything, not that I don't know anything about the p53, but we do know a bit about the germline BRCA. So I would visit with her about that. And maybe there's another method of, because sometimes women will get on these at a young age, and whether it be, estrogen, progestin, oral combination, or whether it be an IUD, and they may not have children for some time, so they'll be on them for quite a long time. So I would want to just give her some conversation around that.
Thank you so much. I really appreciate everyone's comments, and I always learn so much from each of you. Kind of an aside question would be, Dr. O'Shaughnessy, because you raised the question of these progesterone containing, IUDs, which have become so commonplace. And, how do you talk to your patients about, so first of all, let's say a patient that has, this particular patient has leave-for-Mimi, but let's say a BRCA1 or 2 mutation, about the role of progesterone containing IUDs. Is that something you try to help them avoid if possible, or is that something you counsel them that you feel is safe?
I do counsel them to avoid them, and also the oral hormonal contraceptives, where it's continuous dosing, where women don't have a menstrual period. We know that that's a higher risk than having a low dose of each and having a menstrual period. So we do know some things, and because of the physiology around the progesterone as a mitogen for these luminal progenitors, I just don't think you want that. You don't want extra mitogenic activity, and when you've got a germline BRCA mutation. So I think that we do know what raises risk. These women are already at elevated risk. We don't have perfect data that for sure there's going to definitely be more of an incremental increase in risk than an average woman, but it's still, she doesn't need any additional risk. And so I counsel them to consider a non-hormonal form of birth control.
Perfect. Okay. Thank you so much for everyone's insight. So for this particular patient that's very young with a known p53 mutation, we would recommend resection of the phyllodes tumor, and then really a program of carefully designed surveillance for the duration of her life, given the known p53 mutation and the significant history of malignancy within her family. So really highly penetrant mutation.